Thank you, everyone, for joining me today. Now, the role of ovarian suppression in premenopausal ER-positive breast cancer was presented and discussed in great detail at the San Antonio conference. As you know, adjuvant tamoxifen for at least 5 years is recommended for early-stage premenopausal breast cancer. The value of adding ovarian function suppression for women who receive tamoxifen is uncertain. In this early analysis, Cusick and colleagues show that adding an LHRH agonist to tamoxifen showed no significant difference in recurrence risk. In a more recent study, the ECOG 3191 study, this evaluated 345 premenopausal women with node-negative disease in which chemotherapy was not permitted. At a median follow-up of 9.9 years, there was no significant difference between the two arms for disease-free survival or overall survival. The study was terminated early because of slow accrual and therefore is underpowered to make a firm conclusion on survival. Nonetheless, the study population appeared to be low risk, and it's not entirely surprising that the addition of ovarian suppression was not associated with improved outcomes. However, women who develop chemotherapy-induced ovarian suppression or amenorrhea have a reduced risk of relapse, and this was seen in these two trials, the International Breast Cancer Study Group, the IBCSG 1393 study, and the NSABP B30 study. In the IBCSG trial 1393, over 1,000 premenopausal women with axillary node-positive breast cancer were enrolled and received chemotherapy, followed either by tamoxifen for 5 years or no treatment. Patients with ER-positive disease who achieved chemotherapy-induced amenorrhea had a significantly improved disease-free survival compared to no amenorrhea, whether or not they received tamoxifen. In this trial, amenorrhea was defined as the absence of menses 15 months from randomization. And the NSABP B30 trial analyzed the impact of chemotherapy-induced amenorrhea in over 5,000 women receiving chemotherapy. Among the women who developed chemotherapy-induced amenorrhea, here defined as no menstruation for at least 6 months, both overall survival and disease-free survival were significantly increased. And these results were consistent across all subtypes, including treatment arms, ER status, and age. The likelihood of chemotherapy-induced amenorrhea correlated with older age and was less likely to occur in women less than 35 years of age. In 2003, the IBCSG initiated 2 large international phase 3 trials, the Suppression of Ovarian Function trial, or SOFT, and tamoxifen and exemestane trial, or TEXT, to determine the value of adding ovarian suppression to tamoxifen or an aromatase inhibitor, exemestane. The primary analysis, which I'll go over with you in detail in the following slides, in SOFT included over 2,000 premenopausal women randomized to either tamoxifen for 5 years or tamoxifen plus ovarian function suppression achieved by monthly triptyline for 5 years, bilateral oophorectomy, or bilateral ovarian irradiation. Patients were stratified by receipt of chemotherapy. Patients who received chemotherapy required a confirmatory premenopausal estradiol level within 8 months of completing chemotherapy, though adjuvant oral endocrine therapy was allowed before randomization. In the primary analysis, at a median follow-up of 5.6 years, tamoxifen plus ovarian function suppression provided a small but not a significant improvement in disease-free survival compared to tamoxifen alone, with a hazard ratio of 0.83 and a p-value of 0.01 or 0.1. Only after adjusting for covariates, tamoxifen plus ovarian suppression significantly reduced the risk of recurrence. This is the same disease-free survival curve showing the third group, including exemestane plus ovarian function suppression. There was a greater improvement in DFS in the exemestane plus ovarian function suppression group with a hazard ratio of 0.68, with a 5-year DFS of 89% compared to 84.7% for the tamoxifen group and 86.6% in the tamoxifen plus ovarian function suppression group. There was a 19% relative reduction in breast cancer recurrence with tamoxifen plus ovarian function suppression compared to tamoxifen alone, which was not statistically significant, and a 36% relative reduction in breast cancer recurrence with exemestane plus ovarian function suppression compared to tamoxifen alone. When we look at patients who did not receive adjuvant chemotherapy, there were very few breast cancer events. This cohort selected for low-risk clinical pathologic features, including 90% over the age of 40, 91% were node negative, 85% with tumors 2 centimeters or less, and 41% with grade 1 tumors. There were very few recurrences in this cohort, and no difference was seen in disease-free survival among the three groups. At 5 years, more than 95% of patients remained free from breast cancer, and more than 98% remained free from distant recurrence, regardless of which arm they were assigned to. For the patients who remained premenopausal after prior adjuvant chemotherapy, these patients on average were younger, with median age of 40 and had higher risk breast tumors. In this group, we do see better outcomes with the use of ovarian function suppression. In those who received tamoxifen alone, the 5-year breast cancer-free interval was 78%, which improved to 82.5% for tamoxifen plus ovarian function suppression, and 85.7% for exemestane plus ovarian function suppression. We see a similar trend in distant recurrence-free interval. Of the women who were 35 years and younger, 94% received chemotherapy. We see the most striking improvement with the addition of ovarian function suppression in this group. In the first 5 years, approximately 1 out of 3 women assigned to tamoxifen alone developed a breast cancer recurrence, compared to 1 out of 6 women assigned to exemestane plus ovarian function suppression. This analysis was pre-specified, and it was of interest based on earlier meta-analyses that included data from the IBCSG and other groups showing that women under 35 did worse than other premenopausal women with adjuvant chemotherapy only. However, the study analysts did not do a formal statistical comparison because they did not think it was statistically appropriate to do so. Also of note, the age was not stratified, therefore there's no assurance that clinical factors were balanced in these analyses. And this was a very small analysis, in that 11% of the population was under the age of 35. There were more adverse events in the ovarian function suppression groups, though grade 3 to 4 events were generally low. The addition of ovarian function suppression increased menopausal symptoms, depression, hypertension, diabetes, and osteoporosis. Patient-reported outcomes were also presented at San Antonio. They were obtained from about 1,700 women on the SOFT trial. Patients completed questionnaires every 6 months for the first 24 months and then annually between years 3 and 6. Patients who received ovarian suppression were significantly more affected by hot flashes, sleep problems, and loss of sexual interest, which improved over time. This graph displays changes in hot flashes over time. The red line is tamoxifen plus ovarian function suppression, and the black line indicates patients who received tamoxifen alone. Dotted lines indicate no chemotherapy. As you can see here, small improvements over time were seen with the lowest quality of life scores at 6 months, which then improved at 24 months and were similar at the 5-year mark. Hot flashes and sweats were more pronounced in patients receiving ovarian function suppression, with the tamoxifen and OFS group having the worst symptoms. Gynecologic symptoms such as vaginal dryness, discharge, irritation, and sexual side effects were more pronounced in the exemestane arm. Not surprisingly, there were more bone and joint pains in the exemestane plus ovarian function suppression arm. But despite these differences in side effects, there were actually no significant difference between the 3 arms in terms of global quality of life, such as physical well-being, mood, coping effort, and treatment burden. When comparing patients who received chemotherapy versus those who did not, the side effects were more pronounced in the cohort of women who did not have prior chemotherapy. So when one considers this new data from SOFT, perhaps a risk stratification like this could be followed. For patients with higher risk disease, typically stage 2 or 3 with intermediate high-grade tumors, or who are more likely to receive chemotherapy. If a woman is under the age of 35, ovarian function suppression could be recommended to the patient to be given alongside tamoxifen or an AI. For those over the age of 40 who remain premenopausal after chemotherapy, it should certainly be discussed. Likewise, for those patients with lower risk disease, typically stage 1, low-grade tumors who are unlikely to receive chemotherapy, ovarian function suppression is unlikely to provide benefit based on soft data, and the patient will likely do very well with tamoxifen alone. For those intermediate risk tumors, such as higher anatomic stage, lower risk biology, or the converse, lower stage and higher risk biology, the benefit and adverse event profile of ovarian function suppression could be discussed with a patient, but it remains unclear if it should be a strong recommendation. So the conclusions from soft text trials are these. The overall premenopausal population did not benefit from the addition of OFS. Some do very well with tamoxifen alone. For high-risk women to warrant adjuvant chemotherapy and who retain premenopausal estradiol, addition of OFS to tamoxifen reduced recurrence. OFS enables treatment with an AI, which further reduced recurrence in the higher risk cohorts, and benefit from OFS was most striking in women under age 35. Now, when we think about talking and discussing these options with our patients, it might be more appropriate to talk about the absolute improvement instead of the relative improvement. So here we see that the absolute improvement in DFS at 5 years were the following. In the overall population, there was an absolute improvement of 2 percentage points with tamoxifen plus ovarian function suppression compared to tamoxifen alone. In the patients who received chemotherapy, there were 4.5 percentage point improvement with tamoxifen plus ovarian function suppression compared to tamoxifen alone, and 7.7 percentage points with exemestane plus ovarian function suppression compared to tamoxifen alone. The addition of ovarian function suppression certainly increased symptoms and side effects. However, the global quality of life was not significantly different between the two groups, and importantly, the differences that were seen in the first 2 years were no longer apparent at 5 years. And finally, the overall survival benefit is not known. The data are too premature, and it doesn't address optimal duration, especially after the trials such as Atlas and Adam. That would be very interesting and important to know and understand. And with that, I'd like to thank you for your attention.